with the national anthem, followed by the University of Port Harcourt school anthem.
Nigeria, we hail thee, our own dear native land. Though tried we stand, Nigerians old and proud to serve our sovereign motherland. Nigeria, our flag shall lead us onward, yet to find, though tried. And justice reign, in peace or battle, honor, service we contest gain. Hang on to our children, abandoned without stain. O God of all creation, grant this our one request. Help us to build a nation where no man is oppressed, and serve with peace and plenty. Nigeria, may we bless. This our one on the green lowlands and swampy plains of the New Calabar River stands the University of Port Harcourt, a citadel of learning and excellent education. Of academic enthusiasts, searching for knowledge and wisdom, enlightenment, and self-reliance, our mission. Our hope in the future is rooted in our the vision of our father, shining in the skies. Opportunities unlimited and equal. Our progeny citizens of the universe, profound and in the pride of Uniport. Because Uniport.
Thank you very much. Thank you very much. Welcome to day 3. I know you had a pleasant experience yesterday. We are continuing with our 3rd day. So just to welcome you and little about the etiquette of joining this meeting. Please, this is a virtual meeting, so prepare your space. Ensure you're in a quiet, well-lit environment. Dress appropriately. Try to be focused. And every proceeding of this conference is important, so give it your full attention. Avoid multitasking, and also mute your microphones except when you're due to speak. So even when you're due to speak, ensure you are in a less distracting environment so we can hear you. Take advantage of the Zoom platform. The raise hand platform is by your task bar below to indicate if you have a desire to speak, and you'll be recognized before you speak. Also, we have the Zoom platform chat feature too for your relevant comments and questions too. So we wish you a very happy and fruitful deliberations as we go on in our conference today. Be respectful, maintain the highest level of professionalism, and conduct yourself as if you are in a face-to-face setting. Welcome once again. Please, on the chat box, let us know where you are joining us from. Thank you, and God bless you. So make progress now.
Dr. Adeze Chidimaore. She's here with us, and she's the chairperson of today's occasion. And of course, we also have the vice chancellor of our university, Professor Owunari Abraham Goodwill. We also have the head of service of Bayelsa State, Dr. Wisdom Sawyer, MNI. We also have the president of my professional association, Dr. Kenneth Tafa, who is also our keynote speaker. We also have Dr. Golden Honda, the former director of Public Health Rivers State, and several other distinguished guests today. So I will go ahead and give my welcome address. So welcome address presented by Professor Best Odinoha at the day dedicated to public health practice, the first scientific conference of the University of Port Harcourt School of Public Health holding today, Wednesday, 17th September 2025. The Vice Chancellor, sir, Vice Chancellor, Professor Owunari Abraham Goodwill, my Lord, spiritual and temporal, and the recipients of the School of Public Health Platinum Award. The chairperson of the day, Dr. Adeze Chidimaore, the 27th Commissioner for Health of Rivers State, a daughter of most distinguished parents. She is our chairperson of the day. The keynote speaker, Dr. Kenneth Tafa, serial social entrepreneur and national president of the Association of Public Health Physicians of Nigeria, who is our keynote speaker. Deputy Vice Chancellors of our university, Registrar of our university, Dr. Gloria Chinda, and other principal officers of the university, the acting provost of the College of Health Sciences, Professor Ngozi Ekeke, Dean of the Graduate School, my own direct boss, Professor Kenny Kanwa Anele, Deans of faculties here present. Let me especially recognize my own Dean, Professor McLean Akpa of the Faculty of Clinical Sciences, directors of institutes and centers, I want to especially recognize my brother, center leader of AC Puto, Professor DST Algaji. Okay, and then of course the panelists, panel discussion, discussants on the theme of the day, which is on public health practice in the Federal Republic. Dr. Wilson Sawyer again, MNI, a consultant, community and public health physician and head of civil service of Bayelsa State, my friend and medical school classmates. Dr. Godwin Ohonda, Associate Professor of Community Medicine and Public Health and former Director of Public Health, Rivers State Ministry of Health, another of my medical school graduates. It is not a coincidence. It's not a coincidence that we are sharing this stage together. I have to also, a third panelist, Dr. Nera Kadiriene, consultant, community, and public health physician. We also have a fourth panelist, Nosvera Nsigbe of the National Assembly, Abuja. Distinguished guests, professors, lecturers, and supervisors of the School of Public Health. I want to especially recognize my deputy, Professor Charles Tobin West. A former acting CMD of our teaching hospital, UPTH. Professor Alice Nte, my mentor right from the medical school days. Past and present lecturers of the Department of Preventive and Social Medicine, especially our present head of department, Professor Omosigbe Madoka, our immediate past HOD, Dr. Jule, Professor Douglas, Professor Douglas, Dr. Moore, Dr. Alabere, and the others, management and staff of the University of Port Harcourt School of Public Health, colleagues and students of the University of Port Harcourt School of Public Health. Ladies and gentlemen, it is with great honor that I welcome you all to day 3 of the first annual scientific conference of the University of Port Harcourt School of Public Health. Today is dedicated to the practice of public health. The University of Port Harcourt School of Public Health was established in January 2019 by the Senate of our unique university as a semi-autonomous academic center to provide postgraduate training in public health and the allied health sciences. The semi-autonomy of our school gives us the power to set and collect fees and then use the collected fees to run the academic programs, but subject to the rules and regulations of our university. This gives the school the wherewithal to recruit and pay ad hoc lecturers from within and outside the university and from the industry to lecture in its academic programs. The school is thus able to recruit the rich talents of the rich talents in NGOs, private and public and private organizations in Nigeria, ensuring that it has world-class faculty with diverse background, experience, and training. Our school started with 4 academic programs. Now we have 3 PGD programs, 10 master's program, a DRPH, a Doctor of Public Health program, a professional doctorate, and the academic PhDs in nearly all the subspecialties of public health and the allied sciences. The academic programs in the School of Public Health are deliberately designed to be both academic and professional, unlike many others in the university, in the country, to sharpen the research skills of our students and prepare them for a career in the academic. Incidentally, our interest today is on the professional aspect of our programs. The result of these results have been very remarkable, as the graduates of our various programs often secure employment few months after graduation and are known to perform much better than others. In fact, I think we are suffering a little from this success because it seems our students, our graduates are able to secure jobs faster than we are able to make available their certificates. So I'm sure that there are some dissatisfied graduates, but we have to do the due diligence before issuing the certificates. I hope they will understand. The success of our graduates in the labor market and their achievements in their jobs can be attributed to our competency-based curriculum, expertly delivered by our lecturers who are drawn from the academia, industry, and government. We not only teach the principles as is standard in most public health academic programs in Nigeria, but also lay emphasis on the practice to ensure that the graduates of our academic programs are industry ready. The practice is embedded in every lecture given and reinforced with case studies. Unlike, I think this is unique. This is unique to the School of Public Health. We actually use case studies, almost like as it is very common in business schools. So our students also have access to short courses that teach specific competencies that are relevant to their program of study that are certificated separately. So the typical student of the School of Public Health graduates not with one certificate, but several proficiency certificates of the short courses. The practice of public health in the Federal Republic is the theme of today's today's theme. It gives us the opportunity to take another look at public health practice in Nigeria that was seriously tested during the COVID-19 pandemic. We did not seem to fully appreciate it, what it means to have health on the concurrent list in our constitution until the COVID-19 pandemic, when states abandoned the directives of the federal government and did what they thought were best to contain the pandemic within the borders of their states, including a restriction of interstate travels. We also became more aware of the implications of having foreign affairs in the exclusive list of our constitution, as the WHO, other UN agencies, foreign governments, and international NGOs can only deal with the federal government and not directly with the states. This means that life-saving medical commodities donated by foreign organizations could have been diverted to serve political and other non-medical interests. Public health practice is actually of two types: horizontal public health, that is the remit of the medical officer of health, and lately those of the community health practitioners. And then the other type, the vertical public health, that is the playground of NGOs, foreign governments, and others with vested interests. Each type of public health practice has issues that hopefully will be discussed today. Horizontal public health centers around the provision of public health services to members of a defined community, as advocated in the Amata Declaration that established primary health care. It is typified by the responsibilities of the medical officer of health and community health practitioners, who are posted to a geographic geographical area and saddled with the responsibility of ensuring the health of everyone in their posted area of jurisdiction. Horizontal public health is however facing huge problems in Nigeria due to poor donor funding and the increasing cosmopolitan nature of even the traditional communities, such that it is rare to find a homogeneous community in Nigeria. So wherever you go, you will see people from different ethnic groups. So, which means that if as a community health practitioner or a medical officer of health, you have to plan for persons of different ethnic groups, different religion, etc. Okay, so the role, so this is a complication. This is a complication in the practice of the horizontal public health. The role being played by the National Primary Healthcare Development Agency and the state primary healthcare boards add to this confusion, as central planning is their modus operandi and community participation is only a token. In addition to this is the jurisdiction battles between the Ministry of Health and the state primary healthcare board over responsibilities. If medical officers of health are under the state primary healthcare board, who then are their field workers? Who then are the field workers of the Director of Public Health? Incidentally, we have a former Director of Public Health of several years. I'm sure he spent close to a decade there. Dr. Goodwill, I'm sure that he'll be able to tell us a little about this. Okay, there is also a jurisdiction battle between the Ministry of Health and the Ministry of Environment over human health related environmental issues, such as air pollution. Who takes the lead in an issue such as the black suit, crisis that has the potential of significant adverse health effects? I'm sure Dr. Ohunda will also tell us a little about this because he was in office during that time. Vertical public health, okay. Vertical public health, however, is in the ascendancy, not only because they are preferred by donors, but also because they are able to recruit practitioners with specialized skills to deal with the emerging and re-emerging diseases. A lot of the staff of vertical public health programs have backgrounds outside traditional health sciences, but are recruited for their specialized skills. This is, however, causing a lot of disparity in the health sector, as nearly all the professors in the health sector, all the professions in the health sector have registration boards that strictly regulates the profession. For example, health records are moving away from paper-based system to the electronic health system that require a skill set that is completely different from those of the already employed health records officers. The question is it fair to deny a trained data analyst from being employed in a hospital for not having the registration and licensing of the health records officers registration board? Perhaps one of the panelists will be able to help us with this. Vertical public health programs. Vertical public health includes the control programs for HIV, TB, malaria, childhood vaccine preventable diseases, amongst others. It is a growth area that has given very lucrative employment to several public health practitioners because vertical public health programs are favored by donors who see the returns on their investment from the measurable results achieved by the programs. The problem with, however, the problem with donor-funded programs is that they are set up to meet the interests of the funder, which may be at variance with the interest of the recipients. The chairperson of the day, the keynote speaker, and panel discussants on the theme of the day were chosen because of their unique qualifications and experience. The chairperson of the day, Dr. Adezore, is the 27th Commissioner of Health of Rivers State, daughter of most distinguished parents, but choosing on merit as the chairperson of the day for her passion, demonstration of knowledge, commitment to duty, and achievements while in office. Of course, she holds a Master of Public Health degree from the London School of Hygiene and Tropical Medicine, and a degree in International Health Management from Imperial College London. Dr. Ore is a known advocate for universal health care and believes in the importance of clear public health communication to educate the public and build communities' trust. The keynote speaker, Dr. Kenneth Tafa, is a social entrepreneur par excellence and the national president of the 3,000 member strong Association of Public Health Physicians of Nigeria, the Professional Association of all specialist public health physicians in Nigeria. Dr. Kene holds an MBBS degree from the Ahmadu Bello University, Zaria, and a fellow of both the West African College of Physicians in Community Health and the National Postgraduate Medical College in Public Health. He has over 20 years experience in the health and development sector, including jobs with development partners like the American Center for Disease Control and Prevention and FHI 360. The panelists on the panel discussants on the team also have rich public health experience. Dr. Wilson Sawyer, MNI, consultant, community and public health physician, and currently the head of service of Bayelsa State. He is, like me, a 1995 graduate of the University of Port Harcourt Medical School and holds an MPH from the University of Lagos, fellowship of the National Postgraduate Medical College in Public Health, and a member of the National Institute. He just concluded his PhD in public health at the Niger Delta University. Dr. Ohunda, Associate Professor of Community Medicine and Public Health, and a former Director of Public Health, Rivers State Ministry of Health, is also a 1995 graduate of the University of Port Harcourt Medical School and holds a fellowship of the West African College of Physicians in Community Health. Dr. Nera Kaderi, a consultant physician and a public health, a consultant public health physician. She has a fellowship of West African College of Physicians in community health and a PhD in disaster risk management. She currently works as a senior program officer at KNCV Nigeria in the implementation of USAID-funded tuberculosis control projects. And then finally, last but not the least, Nurse Vera Nsigbe, a passionate public health practitioner, nurse with the National Assembly, Abuja. I have no doubt that they will do justice to their choosing team, so the choosing team of the three of our conference. Please sit back and listen to these experts. Welcome. Thank you. So that was my opening speech, a very lengthy one, I must say. So we can have the chairman's opening, the speech, chairman's opening speech. Hello, ma.
Good morning, Prof.
Yeah,
I believe
good
you
morning,
can
ma.
all see me and
Yes,
hear me.
we can see you. Yes.
Thank you very much for the invitation and the opportunity to join you all at the first ever Public Health Practice Day of the first annual scientific conference of University of Port Harcourt School of Public Health. Congratulations. I would like to commend the director, management, and students at the University of Port Harcourt School of Public Health for envisioning and executing this conference, the distinguished speakers who will be sharing their insights, and all public health practitioners who have joined in to participate in this event. Your commitment to the cause for public health in practice is commendable and inspires hope for a healthier society. Nigeria, as we all know, is Africa's most populous country. Although a federation of different states, it is beleaguered by governance complexities and the fallout of decades of mismanagement over the years, and a deeply scarring civil war that cost many lives, and the social effects of which are still felt today in surviving generations. Federal government-driven, state government-led, and non-governmental organizations have operated funded programs which abound in the country and have supported several public health interventions in recent years. Public health practice in Nigeria spans disease prevention and health promotion through community-level interventions, addressing challenges like infectious diseases, malaria, HIV/AIDS, tuberculosis, Lassa fever, Mpox, to name a few, non-communicable diseases, and high maternal and infant mortality rates. Key aspects include community health practitioners providing basic services, as Prof alluded during his welcoming remarks. Efforts to strengthen primary healthcare delivery and the use of disease surveillance for health security. As we all know, these challenges persist, including limited prioritization, under-resourcing as a specialty, underfunded facilities, lack of skilled manpower, lack of essential equipment, insufficient supply chains, and sociocultural barriers. Onweze Golden or Honda will probably have a lot to say about the public health laboratory in Rivers State and the challenges therein. However, advancements and opportunities for technological integration, such as artificial intelligence-powered tools, are offering new solutions for data management and service delivery, particularly in remote locations. The conference and the Public Health Practice Day provide us with a unique opportunity to highlight the importance of capacity development, service delivery, and finally, documentation with monitoring in that order. This will ensure the delivery of improved public health outcomes and enhance financial public sector investments. Today's speakers of truly great stock. The keynote speaker, my blood brother, Dr. Kenneth Tefa, President of the Association of Public Health Physicians of Nigeria, is truly a public health specialist with dedicated practice in epidemiology, medical statistics, public health programming, and entrepreneurship, and one with whom I have had the distinct privilege of working closely from our days together in US CDC for the past 15 years. The special guest of honor, Dr. Wisdom Sawyer, MNI, Head of Service Bayelsa State, panel discussants, Onweze Dr. Golden Ohonda, Pioneer Director of the Institute of Infectious Disease Research and Development, and my invaluable Director of Public Health and Disease Control at the Rivers State Ministry of Health, Dr. Nera Kadiriene and Nurse Vera Usigwe, have all in their various spheres driven successful public health initiatives and provided case studies for learning and scaling across the country and the continent. Dr. Nera, I might add, is a sister, a dear sister of mine. As we begin today's session, and indeed the entire conference, I urge each and every one of you to actively engage in the discussions, share your knowledge and experiences, and collaborate on actionable solutions. Let us harness this opportunity to consider and explore the shared innovative strategies, lived experiences, and synergistic partnerships Let us strive to build a healthier, more sustainable and prosperous nation aligned in one direction and aiming at one collective goal, the improvement of our nation's public health. May our deliberations be fruitful, our collaboration strong, and our commitment unwavering to advancing public health practice in Nigeria. On that note, it is therefore my honor and pleasure to declare open this Public Health Practice Day of the first ever scientific conference of the University of Port Harcourt School of Public Health. Congratulations, and may God bless us all.
Thank you very much, Honorable. Thank you for such a rousing speech. Thank you very much. Thank you. So we'll move on to the next. Dr. Wisdom Sawyer. Dr. Sawyer. I'm sure you'll be. Hello? Dr. Sawyer. Okay. Anyway, he was just appointed, so I'm sure he's trying to get used to his office. But he promised we'll get him. So we can go to Dr. Kenneth Afak. My president, can you confirm your presence? Hello? Dr. Kenneth? Sorry?
Hello, good morning.
Yeah, good morning. Okay, that's
yes, I'm around. I've been trying to unmute myself, but it's been difficult.
I'm that's the MNI in itself.
Yeah.
Yes. So can you highlight him? Okay, Dr. So can you go ahead and give your Goodwill message? Just a brief one, so that we can go and. Yeah.
Good morning, the distinguished chairman and the coordinator of the program, Professor Bess Odinoha, and other members of this panel of the first annual scientific conference of the School of Public Health. Good morning, also participants. I'm speaking from Bayelsa State. I am actually a consultant public health physician, and I've been practicing public health all my life for the past few decades. The School of Public Health that I know in the University of Port Harcourt has been a major pillar in the training of postgraduate materials in Bayelsa State. Right from when I was a permanent secretary in the Ministry of Health during my first tenure, I could remember they have graduated so many, and which have been helping us here in the practice of public health. Most of the graduates from that school are the people anchoring most of the programs for us here in Bayelsa State in the Ministry of Health. Most of them, some of them with masters, some PhD, they are here, and they are making very great input in the various, even in our satellite hospitals like the Tuberculosis and Leprosy Hospital, in the major NGO programs, Heartland and so on, is the graduates from the, even our immunization that you see that we are doing very well, you see that it is their graduates from the School of Public Health. And I think the School of Public Health is doing very well to affect public health practice in our geopolitical region. I don't think it's only Bayelsa State they are training other places. So what you are doing in that school is highly commendable. And I encourage all members of this scientific conference to key into this objective We are not just talking about having manpower, but quality manpower that have been well trained to meet contemporary times and contemporary needs, which is what they are doing in School of Public Health. So I want to congratulate you. And now that I've been promoted, I'm sure it is some of the techniques that I've learned from the School of Public Health that is keeping me here from 2 times tenure as a permanent secretary, Minister of Health. I'm now the head of service in Bayelsa State. So the sky is not our limit. We can even go above the sky as graduates or people that are teaching in the School of Public Health. Thank you so much, Professor Bess Odinoha, with his team. Thank you, participant chairman, for everything you are doing. Thank you so much. Thank you.
Thank you very much, Dr. Wilson Sawyer. I nearly called you Professor Wizzy. And it's good that you are wearing resource control, which means that you are part of the resource controllers. Thank you very much.
I'm now the number 4 man. I'm the number 4 man in the state now.
Good to hear. Good to hear. Thank you very much. So we will go back to the Dr. Kenneth Tafa. I think it was very difficult to unmute. I don't know. Okay, sir, Dr. Tafa, can you just raise your hand so that they will identify you while we get ready for his citation? Have we identified? Okay, thank you very much. Thank you very much.
Thank you very much. Thank you very much.
Good morning, sir. Yeah, thank you. It's good to hear from you. So let's take your citation, and after that, you can go ahead with your lecture.
Dr. Tefa Kene won a unanimous vote to give the keynote address on day 3 of the first annual scientific conference of the University of Port Harcourt. He won the vote for his academic and professional qualifications, his broad professional experience, social entrepreneurship, and most especially as the president of the Association of Public Health Physicians of Nigeria. Dr. Tefa Kene holds an MBBS degree from the Ahmadu Bello University and is a fellow of the West African College of Physicians in Community Health and the National Postgraduate Medical College in Public Health. He also holds a master's degree in medical statistics and epidemiology from the University of Ibadan and is currently pursuing a PhD in climate change resilience and sustainability. With over 20 years of experience in the health and development sector, he has worked with international partners such as the Americas Centers for Disease Control and Prevention and FHI 360. At present, he is fully devoted to his role as president of the Association of Public Health Physicians of Nigeria and to his thriving social enterprises, which include Ave Health Sense Limited, Race for Healthcare Project, Access Bank Solar for Health, Entrepreneurs Network Nigeria, Civil Society, Vigit System, a digital public health solutions platform, among others. The Association of Public Health Physicians of Nigeria is a 3,000-member strong professional body of specialist community and public health physicians across Nigeria. Its members serve in top positions in academics, international NGOs, and government ministries, departments, and agencies. Ave Health Sense Limited, co-founded by Dr. Tefa Kene in December 2014, is a public health social enterprise organization dedicated to transforming research findings into impactful social enterprises that add real value to humanity. These initiatives have won multiple awards, earned massive carbon credits, saved lives, and lifted many out of poverty. Distinguished guests, lecturers, students, ladies and gentlemen, behold Dr. Tefa Kene, medical doctor, fellow of the West African College of Physicians in Community Health, fellow of the National Postgraduate Medical College in Public Health, epidemiologist and medical statistician, social entrepreneur par excellence, national president, Association of Public Health Physicians of Nigeria, and keynote speaker on day 3 of the first annual scientific conference of the University of Port Harcourt School of Public Health.
Dr. Kene, you can go ahead and give your lecture. Okay.
Good morning, everyone. Can you see my slides? Prof, can you see my slides?
Yes.
Okay,
Yes.
so let me start by thanking the Vice Chancellor and the leadership of University of Port Harcourt School of Public Health for finding me worthy to be part of this historic event. I thank you very much for this opportunity. I stand on the existing protocol, but before I move on, I want to appreciate my blood sister, Dr. Ore, whom we have worked for years. I'm happy that she's here as part of this historic event. So the outline is like this. We'll be looking at public health, historic perspective, public health functions, what is a federation, with respect to Nigeria, public health systems in Nigeria, the governance structure, federalism and public health, challenges, recommendation, and then conclusion. Now, the World Health Expert Committee, World Health Organization Expert Committee on Public Health Administration in 1952 defined public health as the science and art of preventing disease, prolonging life, and promoting physical and mental health and efficiency through organized community efforts for the sanitation of the environment, control of communicable disease, the education of the individual in personal hygiene, organization of medical and nursing services for the early diagnosis and preventive treatment of diseases, development of social machineries which will ensure to every individual in the community a standard of living adequate for the maintenance of health. This division means that every individual is entitled to a standard of living adequate for maintenance of health for that community. Now, historically, we look at public health in different dimensions. The policy as known today originated from the Industrial Revolution of the 19th centuries. Initially, it was concerned with hygiene and lifestyle conditions under which factory workers lived and functioned. But of course, it's grew to a point where subsequently it involved becoming a discipline of its own, where most of us, a population of over 3,000 members, live the life of public health physicians. In Britain, it developed into its public health documentaries define public health as an art and science of promoting health, preventing disease, restoring and maintaining health, and of course, prolonging life through organized community efforts. Now, what are the defined public health functions? Now, every country defines its own public health function, but these are the standards. This is a standard approach where every country defines based on this. One public deals with provision of health care to a defined population. So while we care for individuals as clinical service, we look at a defined population, and that population could be as small as 5,000 people, as small as 10 people, as small as big population as a state. It defines surveillance, looked at disease surveillance, outbreaks investigations, policy formulation and health planning, health promotion, just focus on disease prevention at community and personal levels, curative services at the primary care level, of course, looking at health management, including health management information system, because without data, you cannot talk about health management, because we must look at evidence-based information for us to decide what to do next. Of course, public health functions involve provision of leadership to primary care system teams. So these are the general functions that we know. Now, in new public health, there are new dimensions to public health. Now, people talk about politics, but of course, there's a political dimension to public health. Political and practical applications of lessons learned from past successes and failures in disease control is very, very important. Of course, Ebola disease control comes to mind with this. And of course, the latest one is COVID. So we need to understand the political dimensions that influence public health in a country like Nigeria. Of course, the new public health dimensions is looking at population focus, targeting communities. Of course, we also look at these issues from a different complex phenomena that is based on multiple risk factors. Of course, risk factors across Subnationals may not be the same. Of course, we have multiple stakeholders. At times, when you are planning a program, all that you are bothered with is how can you manage the stakeholders? And they come in different dimensions with different interests. Different dimensions with different interests. It involves a rapid range of practitioners. Of course, public health is not just about doctors, it's about complement of all people who are involved in this practice, addressing a wide range of issues, addressing present and anticipated health problems in a complex world with great inequalities and floating targets. Today, we are dealing with social media issues. Now, we are yet to understand the social dimension of fear of missing out. Some people are spending not less than 18 hours or 20 hours on social media activities per day. Some woke up, as they're waking up, they are going to the social media platform. We don't understand the long-term implication of this. Now, the new dimension of public health, again, is how do we sustain our programs? So we must be looking at how do we finance this program? What are the areas that will help us sustain some of the programs that we talked about? So the dimension of public health social enterprise is one of the key things we are talking about. In fact, University of Latvia is doing the postgraduate diploma in public health social enterprise. Now, what are the distinguishing features of public health as compared to clinical practice? First is the pursuit of a collective good. So we look at everybody. We talk about every individual having the capacity to maintain his health throughout the individual's lifespan. In fact, most times when people go to hospitals, it's a failure of the system to protect that individual. And when I say system, the individual himself is involved. The individual herself is involved, because if we're looking at hygiene is personal, but then is the starting point of public health entry, because you must have hygienic environment at the level of family, and of course, at the level of the community. It involves innovation to align with current issues. Now, issues keep emerging. We're talking about resistant diseases coming up every day. How do we deal with that now and in the future? Look at focus on prevention, use of government and collective actions. Now, it's important to understand that, yes, you cannot implement public health activities without involvement of government. So, of course, when you talk about vertical programs, one of the missing links is the fact that the involvement of government and leadership usually is not maximized. There's emphasis on outcome-based approaches, which distinguishes it from other type of practice. Now, let's define what a federation is. A federation is a system of government in which power and authority are shared between central government, in this instance at the national level, and subnational units as states, provinces, or regions. Of course, examples that come to mind often is, of course, Nigeria is a federation, US is a federation, India is a federation. But while on the other hand, a unity government is a system of governance in which all powers are concentrated in a central authority. Examples here are UK, though of course there's some partial autonomy of Scotland and other component of the UK. France, Japan, Ghana, Kenya. So what are the features of a federation? One, tiers of government. You have government at the federal level that focus on defense, foreign policy, and currency. So a state cannot have its own independent currency. Then at the state level, you look at the state, local government, which focuses on health, education, and agriculture. Now, in terms of constitution, the powers are also shared. Now, exclusive to the federal government is what we call powers are shared in different forms. We'll talk about the concurrent shared power, and of course, exclusive to the federal government, and the residual power. Now, what happens here is that certain element of power sharing is completely and exclusive to the federal government. The issue around defense, the issue around foreign policy and currency is exclusive to the federal government. Now, the concurrent list of shared power, which is what is shared with the state, head is on the concurrent list, and they will have the residual component, which is left for state to decide on what to do. Now, again, one of the features of this is autonomy. So you have autonomy of the subnational level. The state have their legislature, executive, and sometimes judiciary. Then, of course, the last component of a federal entity is unity in diversity. So there are entities that by themselves are unique, but they come together to federate as a federative unit. So what are the definitions? And of course, when we're making comparison between federal and unity system of government, these are the differences. First, shared constitutional powers. In unity system, powers are concentrated in the central entity. Of course, autonomy of powers, I mentioned that. Here, there's autonomy. The other unity system, there is no autonomy. Then policy implementation. In a federal system, policies may vary across states due to local adaptations. So that is why you see states taking decisions and adapting to their own local unique entity. Policies in a unity system is uniform across the country. Then decision making, this is very important. In a federating unit or in a federal system of government, decision making is often slow, requiring negotiations and coordinating at all levels. So most times, people will tell you that there's no federal state. So even if the federal government takes a decision, the states need to now review it, negotiate, and these things take a long time, especially for head decision making. At times, by the time decisions are made, so much have happened in terms of mortality. In a unity system, it is faster, so decisions are centralized. Now, when you are making comparison for countries, then you must look at their governance. So examples of federal system, we have Nigeria, United States, India, Germany. Of course, in Africa, we also have Ethiopia. Ethiopia is actually a federal system of government based on the ethnic groups in Ethiopia. Then in South Africa is a semi-autonomous system, though it is defined as unitary because decisions are made, but the provinces also have some level of autonomy. Now, the classical unity systems we have is United Kingdom. Some devolution of power happens in Scotland, Wales, and Northern Ireland. Of course, France is a unity system, Japan, Ghana, and Kenya. I emphasize Ghana here because most times when people are making comparisons between Nigeria, what comes to mind first is Ghana. Now, of course, as a statistician, there are confounding factors when you don't take into consideration the system that exists in such countries. So Ghana is a unitary system, while Nigeria is a federating unit. I mean, it's a federal system. So what happens here is that any decision taken in Ghana today about health system or health policy, in the next few months, you will get it implemented in almost all parts of Ghana. You may take that same decision in Nigeria, it will take you years before that decision is implemented at the state level or adapted at the state level, as the case may be. So this is how the structure is, just for emphasis. The federal government, state, local government. We talk about the key question. We talk about federal units coming together to form a complex entity. It's a complex structure of shared responsibility, diverse political realities and interests, and resource differentials. So one state may have all the money, the other state may be struggling with all the resources that is needed for public health. So it is a complex phenomenon. And of course, one state may have huge political will, huge, that the political leaders are willing to do a lot in terms of health. The other state, there may be crisis with the political system, that what is put in place is even dismantled over a short period of time. The question is not only how health policies are formulated, but also how they are coordinated, funded, and implemented across different levels of government. Yes, you will have good policies, but who coordinates it? How are the resources coming in? Who assign these resources? How much comes in? Very important. Of course, implementation across board may help, but most times you have issues of adaptations. When policies are made, one state may have a good health system, one state may have experts who are willing to adapt such and implement. The other state will be struggling with experts to do that. So in terms of governance structure, let's look at governance structure and the responsibility of various levels of government. At the federal level, they set policies through the Federal Ministry of Health, coordinate disease surveillance via the National Center for Disease Control and Prevention, and oversees tertiary health institutions. While the state manages secondary health care services, implement health policies, and fund states' public health programs. The responsibility of local government is primary health care delivery, community mobilization, and grassroots health promotion. So what are the strengths of federalism and public health in public health? Now, it's important to understand this because most of us design the vertical public health and, of course, the horizontal public health. So in terms of strength, Proximity to communities enable local adaptation of health policies. Yes, the subnational level is close to people, they can mobilize stakeholders within a short period of time. There's uniqueness of the environment, and of course, they can design based on those entities and community interests. The weak point here is that there's fragmentation of policies and duplication of efforts. In terms of strength, autonomy happens at that level. So state level autonomy fosters innovation and responsiveness. Yes, because if you understand the community very well and you can innovate to fit their purpose, then it becomes very easy to implement programs and policies that are defined by the federal government. There's also shared responsibility that allows burden sharing in emergencies. We have seen this in COVID, we have seen this in Ebola response, where the emergencies were responded easily because they were unique contexts for those locations. We saw the efforts of Lagos State government, the effort of Rivers State during the Ebola response that stood out in terms of responding to the entity. Of course, at that time, it is the understanding of the terrain that becomes very important, is the autonomy that allows states to take rapid decisions that becomes very important. Now, in terms of weakness, there is very political, we have just mentioned that before, capacity across states. So political will is very important. You can't do public health without political will. Get it right now and understand that. Get used to it. Because if you don't understand the dynamics of politics in a particular setting, it's at subnational level, you cannot implement policies at that level in an efficient manner. So we need to understand the dynamics, understand the policies, and governance political way to get results. But this is one of the weaknesses. You may do well in one state, you are happy that, oh, this is happening. You move to another state, the next thing you see, oh, nobody's interested in what you're talking about. There are also inequalities in health outcomes due to uneven resource availability and distribution. When we talk about resource availability, we're not just talking about funds, we're talking about capacity, the purchasing capacity of individuals. You may have a program that requires just simple transportation to a facility to access such a program, such a project. The individuals in certain states may not be able to afford such basic things as transportation to that location. So you must factor in based on the state you are working in. So what are the challenges? We need to look at challenges. One is to look at the Constitution of Nigeria and what is provided for public health. The Nigerian 99 Constitution put health on the concurrent legislative list, which means that both the federal and state government have the constitutional power to make laws and policies on health. This shared responsibility talk about jurisdiction often levels to overlaps of efforts. So we may take a decision at the federal level, and then at the state level, someone repeat the same process, but in a different dimension. It brings about conflict in public health practice. A state may decide to say, okay, fine, yes, you have taken that decision, but we are not buying into that. And then that becomes a problem. Both the federal Minister of Health and state Minister of Health can set policies on primary health care, sometimes causing confusion about who is responsible for funding, staffing, or regulations. Of course, Professor Best mentioned this in his opening remarks. Yes, we face this a lot. In fact, primary health care is one area that we have struggled with the complexity in terms of the implementation. We're talking about the health system that comes with policies at the federal level, but then we have to deal with communities. Communities that need this intervention of this nature to be involved, and most times it's a major challenge. Public health thrives on coordination, but federal system often emphasizes autonomy. So we're looking at coordination in an entity, but then the emphasis is, oh, you can do what you want. So how do we manage that? Balancing the two forces is at the center of effective public health practice in federations. With the local government autonomy bill signed in law, is the concept of primary care under one roof implementable? Who owns the PSC? Is the medical officer of health under who? Is it under the chairman of the local government or under the state? These are issues that people who come into leadership, especially at the local government level, are yet to understand. Local government chairmen are elected as politicians. So you come here and ask them, okay, fine, honorable chairman, we have this project, and he's looking at, oh, who do I report to? Where does the power lies? These are complexities that comes with a federating entity and with respect to primary care that we practice. So let me explain a scenario concerning the concurrent list of problems that we'll talk about. All the 3 levels of government can legitimately claim responsibility for primary care. Very true. So because head is on the concurrent list, so federal governments can talk about through the primary care development agency, oh, that will own this. But there are duplications. The federal government may post head workers, as is happening now with the national fellows, to primary care facilities, while the state also deploys staff there. Who will supervise who? Now, even if we design this on paper, in reality, we are talking about relationship. We are talking about punishment. We are talking about reward. So who supervises who? Another issue is funding gaps. Local government may not invest in PSCs, expecting support from the states. And the states are looking up to the federal government without resulting perpetual underfunding. So, of course, one person is asking who comes to do what. And of course, if we say it's everybody's business, it's nobody's business. So who funds the PSC? Is it the local government chairman that comes in today that will raise the funds? Is it the state or what? But of course, individual, everybody's shifting blames when things happen wrongly. Accountability dilemma. This one is huge. Accountability dilemma. This one is huge. When things don't happen right, when the PSC fails, who is to be blamed? Is it the chairman of the local government? Is it the state governor under the state primary care development agency? Or is the federal minister of health? Or is the primary care development agency? So it's important to understand some of these complexities and find ways and solutions to deal with it. So what do we do? Let me just give examples where we're having huge issues of what works and what have not worked. So policies that have worked across federated units, the policy around epidemiology response, the National Center for Disease Control and Prevention has actually responded well in terms of structure. So every state now has an epidemiology unit at different levels of development, but there's an epidemiology unit with a command center where information comes centrally, and of course, information also gotten at the local government level. This is one entity that have actually saved us during Ebola and during COVID, and of course, potentially have all the system in place to save us from epidemics. The one that has complexities that I've just explained is the National Primary Care Development Agency. Now you have beautiful designs. Can you see a level 2 PSC well designed with all the requirements, but implementation is at different levels. This is a typical PSC that you may see in other locations. Look at the roof, but it's a primary care facility. Can you now compare this with what is designed as level 2 PSC? So there are complexities that need to be clarified that we need to deal with in terms of planning. One policy at the federal level that have actually had delay milestone, which my bloody sister, Dr. Ray, knows about very well. The National Blood Transfusion Service, the National Blood Service Commission. It started at National Blood Transfusion Service, and the idea was that Nigeria should have a centralized system of blood where blood is tested that is available for people to use at all times. And the states should kill it. The states should look at how would they now have their own unique blood service system that is centralized, so that if there's disaster in one part of the country, within the next 30 minutes, the available flight takes blood for that use. As I talk to you now, 1.8 million units of blood are required every year. Nigeria has not met that target because everybody at the subnational level is using blood transfusion, blood units within the hospital system. So when we have emergency, it's difficult. Again, it's something that can be done. It is doable. It is possible. Now, if every state now have a blood service commission and targets 100,000 units of blood per year, by the time you multiply that with 36 plus one state, then you have the target overshot every year. But you know that with this blood, we can have platelets and other components that can be used for healthcare in Nigeria. As I try to summarize and then round up, let me make some few recommendations that I think we should pay attention to. First is We should clarify roles and mandates across tiers of government. There should be no duplicity of efforts. It should be clear. We need to strengthen coordination, intergovernmental coordination. At the national level, we have the National Council on Health. What can't we mirror that at the state level and have the State Council on Health? It's important to understand that, because if we have State Council on Health, when new local government chairman comes into leadership, the first thing that happens is that the council can have a stakeholders engagement. The council can have every quarter have engagement with the local government and say, this is how we should operate. But as it is now, there's National Council on Health that decide, but then in most states we don't have state councils. It would be nice for us to start thinking about having state councils on health. Enhance sustainability financing, sustainable financing for public health. We need to create dedicated funds for public health emergencies and preventive health programs. You see, the university have created the School of Public Health, which means that it has some autonomy. If we now have dedicated funding within the state, it means that those funds can be available at all times to design our programs that can prevent emergencies. And when emergency does occur, response is rapid. State will allocate a fixed percentage of their budget to public health. That is key. We also need to invest in human resource for health with respect to public health. Again, everybody coming to the space now, but there's no structured training that people can talk about. Now, that is the gap the School of Public is addressing, and it's great that people are giving testimonies of what is happening in Port Harcourt. We must define public health functions in Nigeria. As it is now, we have no clear definition of what is the public health functions in Nigeria. Importantly, we cannot take decisions in public without data. Improve health information and surveillance system to ensure that states, local government at all levels generate information that is available for decision making at the state level, at the local government level, and of course, importantly, at the federal level. Now, let's look at the association we'll talk about. Association of Public Health Physicians of Nigeria. Over 3,000 members. What can we do? What can we contribute? APHN should see herself as a technical leader and a bridge builder within the Nigerian federal system. Because, of course, look at the picture here. We have members across the entire country. So we should be bridge builders. As a public health physician, I should find myself in Sokoto one day doing a lot of work. The next minute I'm in Bayelsa. The next minute I'm in Rivers. That means I'm in Lagos, Kaduna, Benue, everywhere as a bridge builder. That way we can translate what we talk about in terms of public health to how these things impact society. So we'll do policy advocacy and leadership. We should prepare ourselves. And policy advocacy is a continuous process. It's a way of life. Reminder all the times that things need to be done this way, things to be done this way. And then we need to demonstrate how these things can be done. We should prepare our members to build capacity of themselves, but importantly, capacity of other members of the team in public health, where we develop workforce that align with the work we do. Technical expertise and research should be what should be intentionally engaged in. Now, when we talk about technical expertise, we must demonstrate what we want to do, what we want to see. It's for this reason that we're trying to see implement the APHN adoption policy or PSCs. Now, the idea is that we can adopt this PSC, do some stuff there, talk about innovation, capacity building, research, and service delivery, where we can now demonstrate our capacity and then use these entities as advocacy tool. Oh, we are not just talking. We have done this, we have done that, we have done that, and this is what is capable. As I talk to you now, Dr. Philip Adie is in Ogoja attending to one of the PSCs that we plan to adopt with the partnership with someone in Canada. These are some of the things that can help, because with this, we can also look at the diaspora remittances that can help us put basic equipment in those places, including solar solutions and innovations, even telemedicine. So we should be able to do things that we can now showcase to politicians who we may necessarily need at all times. And of course, we should befriend them. We should befriend them by demonstrating what is possible. We look at community engagement and accountability, looking at how we can engage communities. And we're not talking about communities as in the structured communities. Now, communities are hybrid. For every village, there's someone living in Ghana, there's someone living in Canada, there's someone living in US, UK. So we can look at these communities as hybrid communities and engage them to bring resources together and improve their health system. Now, that way, as an association, we'll be making contribution. Emergency preparedness and response, of course, this is an area that is us naturally. Intergovernmental coordination, we belong to everyone. So we should find ourselves working with all levels of government, making sure that we now make our contribution and, of course, emphasize areas that we need to be improved on so that the health of people will be guaranteed. Importantly, building capacity. In our leadership, we have targeted ourselves that in the next 2 years, we will have signed MOU with at least 20 partners. Now, what happens? For every partner you go into partnership with, that partner becomes the partner of your partner. So that way we can influence decision making. So when vertical programs are being implemented, we are at the same table. Now, if we are not at the table of change, we cannot change systems. And for us to be at the table of change, we must have multiple partners. We must engage with stakeholders, and we have the capacity. Look at the population. Look at the population we have. On that note, I want to conclude by saying that if one part suffers, 1 Corinthians chapter 12, verse 26, if one part suffers, every part suffers with it. If one part is honored, every part rejoices. That is the issue with Nigeria. We cannot isolate one state and say, oh, this state is doing very well, while the other states are not doing very well. At the end of the day, the indices are aggregated. And once they're aggregated, it's the same Nigeria indices. So we must look at interconnectivity of individuals, communities, and at all levels of healthcare system. Public health practice is in a federal republic is an exercise in negotiation. So we must learn negotiation skills, look at issues in terms of negotiation. How do we now coordinate? How do we now share responsibility? So public health practice in a federal republic is an exercise in negotiation, coordination, and shared responsibility. On that note, I want to recognize, appreciate, acknowledge, and respect the following people: the leadership of University of Port Harcourt School of Public Health, Dr. Best, and the Vice Chancellor of the university, all my colleagues in that university, and of course my blood sister, Dr. Ore, the Rivers State Commissioner of Health and Human Services. I want to recognize my mentor who contributed to this slide, Professor Clara Ejembi. Dr. Lera contributed to this slide, one of my mentors too. And my IT expert in the house, Mr. Daniel Odia, the head of innovations and HME of our organization. And the person I call my remote control, Stephanie Usa, for all that you've done to prepare these slides and get the best out of this presentation. My Rivers people, oh goodness, you made me the Amayana of APHPN. I carry you all the time in my heart. And of course, I'm so proud of you. I am happy that we're doing this historic event that made me the first public health physician, president to make this presentation in Nigeria is what I will ever cherish. I want to thank the entire board of APHPN, NEC, and members of the association. I want to thank you very much. Why would I say this? I want to say that we can confederate. We must retain our unique beneficial identities for common good. Thank you and God bless you. Enjoy yourself and have a wonderful time.
Thank you very much. Please, a standing ovation for the keynote speaker, Dr. Kenneth Tafa, President, National Association of Public Health Practitioners of Nigeria. Thank you very much, sir.
Thank you, sir.
Let me say that because this conference is predominantly to serve the needs of our students, Dr. Kenneth Tafa had just delivered the lecture, so you should respect it in the next exam. So you better the slides will be made available, and they will be expected to answer the questions. Thank you very much, sir. And so we will take a small an interlude. We'll take a cultural display, and after that, we'll just come back for the part 2 of the of the activities. You know, in River State, we tend to work and said that movement, the movement of the waist, when we dance is basically to mimic the movement of the fish. Okay, thank you very much, and welcome back. We just watched cultural displays by the various ethnic groups in Rivers State. I think we can move on to the next phase of this day's activity. So we are getting into the panel discussion, and then we have Dr. Godin Ohunda. Dr. Ohunda, can you indicate by raising your hand so that we can? Hello, Dr. Ohunda. Dr. Sawyer, who is on Sawyer? Dr. Sawyer, I hope you are still on call. Dr. Kadiri Ene, I don't know if she has been able to join. And then Nosvera and Sigwe. Okay. So I think we are going to allow the panelists to probably give a brief opening remark before we go into the question and answer section. Is it possible to? Sorry. Okay, so can we have Dr. Godwin Honda? Dr. Honda, your opening remark, sir.
Thank you so much, everybody who is on the call. Thank you, Harold Omishana. It's a great delight to be on this call. I mean, I've enjoyed every bit of it, and thank you, Dr. Kene. It's did justice to the topic, and it's been very fruitful and engaging, and I look forward to more deliberations. Thank you, and over.
Thank you very much, Dr. Sawyer. Hello, Dr. Sawyer. Oh, sorry, I forgot to say that you also hold the traditional title of Onweze of Rebisi Kingdom.
That is correct. Thank you.
So you should be addressed as is it Dr. Godwin Honda?
It's all fine. Thank you.
Okay. Okay, so we can go to sorry. Okay, Vera and Sigwe, can you also make your opening remark?
Thank you very much. Good morning, Chairman. Good morning.
Hello, Vera. Can you unmute and say something, please?
Can you hear me, sir? Hello, can you hear me? Hello? I've muted. Can you hear me? Good morning, Prof. Can you hear me? Hello?
Okay.
Hello, can you hear me, Prof?
Dr. Kadiri, I don't know if she has been able to join. Dr. Kadiri. Oh, she has. Okay. Okay, so let's just continue with Dr. Honda. Dr. Honda.
Yes, I can hear you.
Okay, we have a lot to learn from you, considering the many years you spent as director of public health in the Rivers State Ministry of Health, especially during the COVID period. and even during the black suit period. So you have your reign, or should I say your service as a director of public health was very, very eventful. Can you just tell us about let's just start with the pandemic. The pandemic. How were you able to keep the number low and the mortality even lower?
Okay, thanks so much. I didn't anticipate that you were going to ask about the pandemic, but it's contextually speaking, it was a very challenging period for us, basically because the disease was new and also in evolution. So it challenged both our technicality and our courage. It challenged ability to invest resources to achieve overall goal. So it was a pretty tough time putting all this together. But the greatest part of our success was coordination, working together in a coordinated manner in such a way that we are able to, as a federating unit, leverage on a central coordination system to be able to reach global standards. So this was particularly one of our strengths. And we drove that basically through the Public Health Emergency Operations Center, which for us, for a long time before then, had been had not been very palpable. But the advent of COVID made it possible for us to bring the PHUOC out of academics and put it on the ground. And we saw very clearly that it was demonstrably very effective. And we also commend the government of the time because they also realized that it was a challenge and began to work towards it. If you contextually place it in the things we've looked at today in terms of our federating unit, you will see that yes, like Dr. Kene had also mentioned, there is politics and governance also affecting every bit of public health programming. You will also see the advantages of programming from the top and bottom-up programming. You will realize, as Kene has said, that there's a bit of social enterprise that affects outcome of what we're doing. And some of the things that you see is that in the federal, you may have a bit of a difference in terms of policy and direction, but when you get to the local level, contextually speaking, you have to apply it to be able to meet the standards that can give you results. So we saw all this play out during the COVID. What is most interesting is that our federating unit for programming defines unity in diversity. It's probably not the same for many other societies outside Nigeria, where sometimes in most of the developed climes, you are allowed, the health system is allowed to, formulate their policies to give us an indigenous context. But for us, we have to align to national standards. And that gives them a very wide spectrum of control, very wide spectrum of supervision. And sometimes when you try to operate with the concurrent standards in terms of our constitution, so that you have an adaptation to a variant, you find that it is a dead end. You don't have anywhere you can fit it in. You have probably sometimes, yes.
Okay, I realized that you were the incident, is it commander or what? It's
incident manager.
Anyway, it's a war, so you are called a commander then. But some of the public interface,
yes.
We saw a lot of should I say lay persons getting actively involved in health communication. In fact, I still remember is one phone-in program, Saturday phone-in program, when the commissioner of information was the only one there. So did you provide him with the necessary materials to make such communications?
You know that I will not be able to answer that question very directly, Prof. But what is important is that in the PHUC, we have standards for communication. The PHUC is very interesting, and I think that all the students should learn from it. Basically, because it is an incident command system. In the incident command system, there is hierarchy of commands. There are protocols for engagement. So before any member of a PHUC can engage with and the
general public.
Yes, there are protocols in which he has to follow, and he must get the permission of the incident commander or incident manager before he engages. And he will manage that communication in accordance with the laid down principles for communication, which basically affects only that disease entity. Yes.
Okay, so the chain of command, does it extend to the other those in the political circle or the political appointees?
Yes, you realize. Go ahead, please.
Yeah, because you know, when what we saw abroad would be that even when probably the prime minister will be making the communication, we just say something, but the technical aspects will be the expert making the communication.
It's a great standard. It's a great standard to look up to. You know, like I said to you, this was a period of dynamism for us.
So from what you can, you had a very good relationship with the federal government, especially during the COVID-19 during the COVID-19 era. You had good relationship. That's what you said.
Yeah, the federal government was very interested, but not just in Rivers, but basically all states, because you know the law of averages. If you can control COVID in Sokoto State, it's going to spread to neighboring northeastern or northwestern states, and it's going to spread across the whole country. So they had interest to ensure that every state was above board.
Okay, so let's go to the normal times. Disease control.
Yes.
What's the relationship between the ministry, especially your office, public health, and
hello, can you hear me? Yeah, I lost you for a moment. I don't know. Okay.
They can hear. Yes, it's on.
hello.
Yes, yes, we can hear you. Yes. We can hear you now.
Hello.
Yes, we can hear you. Maybe not as clear as before, but we definitely can hear you.
Oh. Should I use it? Hello.
Yes, we can hear you.
Sorry, apologies. Network took me off.
Okay.
I was just asking. Do you have staff at the local government level that report directly to the director of director of public health?
Yeah, I mean, this is a very interesting question. And that brings us to some of the things that Kenneth had already spoken about. In terms of governance, governance in Nigeria is in 3 tiers, 3 sectors, the federal, the state, and the local government. It is the same for a healthcare system. The healthcare system mirrors that performance. So you have a tertiary healthcare tier, you have a secondary healthcare tier, and then you have a primary healthcare tier. The coordinating and central unit, which is melting point, is the Ministry of Health, which is apparently led by the Honorable Commissioner for Health. So basically, it's a web structure. The policies are digested from federal down to the state. The state has adaptive capacity to ruminate on this and give it some local context, and then spread it through the 3 tiers of service delivery that is available in the state. So everybody within the state is answerable directly to the Honorable Commissioner for Health in that system. So it is not like the commissioner has to have a direct control with the manager of the health facility. No, what it does is the commissioner for health has direct control on the operators of the primary health care. The commissioner for health has direct control on the chief medical director of the board. And of course, if there's a teaching hospital in that state, like we have in River State, the teaching hospital is answerable to the Honorable Commissioner for Health. That way, it's a coordination team. The Honorable Commissioner sits in the middle and has direct control through all of them. The programs run through these systems, and the programs have their melting point right also in the ministry. So all the directors and all the programs under them feed the Commissioner for Health before it can be escalated to the federal. This is how our system looks like. Is it my network or is it your network?
It's all right. Thank you very much. We'll continue. Dr. Honda, are you still around?
Yes, yes, very much.
Sorry.
Yeah,
Apologies. Apologies. Well, it's all right. So can you just tell us a little about the black suit before we go to the others? Vera, I'm sure that Vera is still with us.
Okay. Yes, the black suit was another period of challenge as a public health director, because of course, you know the consequences of suit. We were also particularly concerned because we were worried about where it was being generated from. When the suit was first cited in Rivers, we didn't know the source very exactly because it was strange, it was new, we didn't know where it was coming from. The administration of the day had felt that it was important for us to have a collaboration, a One Health system, to be able to look into it. And a lot of factors came in. We brought in very distinguished colleagues, including your humble self, Professor Best, Professor Madoka, from the health sector, from the environmental health sector. They also brought in, from the environmental sector, they also brought in Professor Ede, and we all put our heads together to, try to be more scientific about what the black suit was all about. And what we found was, first, we tried to use wind modeling and characterization in terms of phytochemistry to determine what it was, where it was coming from, and then we also had to determine the health effect. It was very instructive to note that the health sector was actually left out in the mix of things in the early part of this arrangement. It was later when they realized that the environment is about health, that the health was brought in. And by that time, some work had actually begun. But what we did was to find out truly if the suit that we see we had any reason to worry about in terms of our health. And this is why students also have to take the work that they do in academic very seriously. This is a time when we sat together and said, how can we determine that the suit that we see has a deleterious effect on our health? So we did a conceptual design of research, which was a before and after. What can suit do? Has it done it? And so we did a before and after design. I can't remember exactly, but probably drawing over 40,000 health records from across the country, from across the state before the advent of the suit and after the advent of the suit. That is when we noted it. Because it was a quasi-experimental study, it was easy for us to formulate a hypothesis. Because suit, as suit falls to the ground, it degrades very quickly. So we set out with a null hypothesis that it had no effect because it degrades fast. But what we saw in terms of cardiovascular effect, in terms of rising levels of cancer, in terms of significant changes of difference in difference that we're able to demonstrate, we're able to throw away the null hypothesis to show that, yes, it had a deleterious effect on our people. And we're able to foster recommendations in which the state government actually took to heart and implemented at that time, one after the other. I think it was probably some of the things that led to the foundation laying of the Cancer and Cardiovascular Center. And we in community health very strongly felt that if the community was part of this effort at containing the suit through advocacy, risk communication, we would be able to all this worked well for us.
In fact, I was getting to risk communication, because that's, anyway, I think it's our common, is the example we commonly use during in our lectures on risk communication, considering the agitation of the general public. How were you able to manage that aspect?
Yes, risk-com is pretty interesting. In fact, I can tell you, like for COVID, it looks like a leaking bucket. Sometimes you are trying to throw out information for everybody to be able to understand, very experienced and technical people, lay people, everybody. You have to throw out this communication so that they understand. We also found that it is important to keep the communication fully occupied. Immediately you take your hands off the throttle of your gas, the next thing you see is a lot of meats just fill it up. So we in order to be able to do this, we set up a team at that time which we called meat busting teams. And what we do was look out for meats. Once we find a meat, we find a way either using infographics or radio or whatever means we can to bust the meat to show that it wasn't. Those days when people had to take light bulbs, put on their shoulder and say that they had a COVID vaccine and now the light bulb is coming on, they have become electrified. So we had to do a lot of meat busting, show that that was a toy that you could buy elsewhere in the market. So we did a lot of that meat busting, and we utilized a lot of social media. We realized that most of the mythologies and the disinformation that was being passed were actually happening in the social media. So we had to walk our way right into social media space. Dr. Maduka was very useful for the team at that time because she helped us prop up the social media work. As civil servants, we like to stay away from social media, but this time we had to go right deep into it. We established what was called a tweet deck. So if you just write, I had COVID, in Twitter, we'll see it right on the dashboard in the state ministry of health. And we used all these methods for communication.
And interestingly, the state the Ministry of Health and even the primary healthcare agency, they are going big on health communication, because I realize that we now have a health communicator, and then even at the local government, health communicator, and so forth, because it's very, very important. And we even have a program on health promotion and communication, where we even teach them that you can medicalize talk. Talk can be used as medicine, especially in behavioral change communication and the rest. Thank you very much, Dr. Hunda. So I don't know if we can get to Vera. Vera, are you there? Hello, Vera. Yes, if you can just unmute. Sorry, the technical difficulties. Oh, Vera's voice. Vera's voice can be low. Okay, it's all right, I'm sure. Dr. N actually went for a visa interview today. I don't know if she has finished. I hope so. And if she will be in anyway, I hope they grant her that visa so that she'll be in a good mood to speak to us. Dr. N, if you are there, Dr. Sawyer. Okay. Okay, so we don't actually. I don't know if there are other, but is Vera still struggling to talk to us? Okay. Thank you very much. Thank you. I think on this note, perhaps I should give the chairperson opportunity to give our closing remarks so that I can. So I will just start the closing formalities. I hope she's still there.
I'm very much here, Prof. Been
okay, ma. Apologies.
Enjoying the discussions. I had said before that Dr. Kene is a public health specialist. I don't know what to title Onweze. Onweze, what should we title you? Because your submissions were excellent, and it just brought me back to the times when we had responses to infectious diseases in my time in the River State Ministry of Health, where my colleagues would say that I seemed so calm in the face of those outbreaks. And I said, you do not know the invaluable assets that I have in the state ministry that are making me, and in the emergency operations center in the state, that are making me so calm. Thank you for all your service to the state and the value that you continue to bring to the practice of public health. So on that note, Prof has asked me to conclude my assignment this afternoon as chairman of this Public Health Practice Day. And of course, as I've just said, I'm especially delighted and heartened by today's discussions. And permit me to just emphasize a few things that I believe we should be living with, to deliberate on, to chew on, as we think of furthering public health practice in our dear country. The first is the intersection between political will and public health. Second is clarifying and defining roles in public health to avoid overlap, to avoid friction, which contributes substantially to the challenges that we face in the field. Intergovernmental coordination, and of course, the consideration of state councils on health. Some few states have actually started carrying out this, and I think it's something that should be scaled and should be sustained. And the role of associations like the Association of Public Health Physicians of Nigeria in bringing their technical competence and building bridges and supporting in capacity building for a sufficient pool of proficient public health practitioners. So on that note, I sincerely thank the coordinator, the director, the management, and of course, the students of the School of Public Health of University of Port Harcourt, all the participants who have joined in and engaged fully in our discussions this morning into the afternoon. And I charge us all to continue working assiduously towards strengthening public health practice, not just in Nigeria, but on the African continent and on the globe. So thank you all. Thank you for lending your experience, your expertise to making this an exceptional Public Health Practice Day for the first ever scientific conference of the School of Public Health at the University of Port Harcourt. Thank you for the honor accorded me today, and may God bless us all.
Thank you, Ma. In fact, I've noted 5 points, and I'm sure that the students, they have also noted them because just as I said earlier, they should expect them in their next exam. Thank you very much, Ma. Thank you. I can't thank you enough. Despite your busy schedule, you stayed with us from the beginning to the end. Thank you very much. Thank you, Dr. Kenneth Tafa. Thank you, Onweze. Thank you, Vera. I'm sure that if not for technology, it would have given us your insight. Thank you, the participants. A lot of you joined the Zoom. Even many more watched the live streaming. Thank you very much. I think we will end here this section now. To around 4, we will start the scientific section with your abstract presentation. Please, 4 o'clock. You will have already listed those to present, please. So when if you have been listed, please be present, and we also invite others to join, not only to learn, but also to be able to ask for clarifications. Thank you very much. So on this note, we will first of all take the national item, and then the University of Port Harcourt item. National item, please.
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians old and proud to serve our sovereign fatherland.
Thank you very much. So we have come to the end of today's this morning's activities. By evening around 4, we are going to start the scientific section. Please, thank you very much for attending. Thank you. Thank you very much. So see you by 4 today. So thank you very much. Anyway, so if you're around the University of Port Harcourt, you can come down to the office of the School of Public Health. Okay. Thank you very much. Thank you for joining, and apologies for the technical difficulties we faced at some point. Thank you. Thank you.